We've all heard the phrase, it takes a village to raise a child. But the thing that we often forget is that it also takes one to support the mother.
Well, speaking of the village, this is our podcast. I'm Nicole Harlow.
And I'm Dawn Thompson. And we're here to connect you with a village of support you need from pregnancy to parenting.
So come on this journey with us as we build your village one episode at a time.
All right. Well, hello. My name is Dawn Thompson, and I'm here with my wonderful co-host, Nicole Harlow, today. And our guest is Ginger Breedlove, who is a dear friend and someone I just admire tremendously. And I think the work that you are doing, Ginger, for Midwifery is just enormous. And you are a midwife, former president of ACNM, which is the American College of Nurse Midwives. And currently you're the CEO, correct, of Grow Midwives?
Right.
That's awesome. Well, would you just introduce yourself, kind of give a little bit of background of who you are and why you're doing what you're doing right now?
Sure. It's great to be here, Dawn and Nicole. Hello. I'm very excited to be a part of any conversation that talks about childbearing for families and how we can help folks understand the landscape as well as how to advocate for themselves. So it's a true honor to be here with you. I've been in maternal child health now about 48 years. It's the only thing I know, starting out as a labor and delivery scrub tech, which is the bottom of the food chain in the green tile delivery room, and handing the doc the instrument and wiping their brow and doing all kinds of horrible things to families. That was my first introduction to obstetrics back in the late 70s. Leather hand restraints, fathers in the waiting room, separation of family. So I've watched the evolution of birth in the hospital to what it is today, which could be very similar to that in some places, to being very much like what we call freestanding birth centers, where it's much more open-centered care. My most recent career path started 8 years ago when I decided I needed to do something to help our profession, midwives. And in particular, our focus is on nurse midwives and certified midwives. So those of us who have gone through graduate education, there's about 15,000 certified nurse midwives and certified midwives in the US. And we are the predominant practitioner when you hear the word midwife, although CPMs and licensed midwives are about 3,000, and they primarily focus on home birth or birth center birth. In our work, we have grown to primarily focus on a midwife looking for help with employment contracts or work conditions or how to start their own business, to, I would say, 4 buckets of consulting work. We are helping midwifery education programs grow around the country. So we are finishing up our 5th graduate nurse midwifery program in the nation, with 2 more in the pipeline in 25. So that's 7 new programs in about 3 years. We help hospitals start midwife services. Several have started from the ground up. Others we've helped expand. We work with private practices and federally qualified health centers start, or let's say, smooth out challenges with midwife services, not knowing how to bill appropriately or even have good, healthy work-life climate. And we help individual midwives, again, whether it's start a business or review a contract. And so we really have expanded all of those services over 8 years to include a billing company in the last 3 years that bills for midwife, birth centers, and blended models. And our overall goal is to scale up and sustain midwifery in the United States. So I'll pause there and see where we go.
Well, I mean, I'm imagining that there are pregnant women, hopefully early pregnant women right now that are listening. And so many people don't understand the difference between a midwife and an obstetrician. So maybe we just start there with the basics, something so basic as that. Or like people think that like, oh, midwives are just for home birth, or midwives are just for unmedicated birth, or, you know, like all of those sorts of things. So let's dive into that a little bit.
Sure. I think it's important to understand that midwifery in the United States is very nuanced. If you come from Europe or you've had a baby anywhere in Europe, midwives are very integrated and they are the primary gatekeeper to a positive pregnancy test. The midwife is the one who listens to what you want and sort of leads you in the direction of where you want to go. Home birth, maternity center, hospital, high risk OB, right? And the ratio of midwives to physicians in Europe is the inverse of what it is in the US. The best model is the UK, has 35,000 midwives and 1,500 OB surgeons. In the United States, we have about 40,000 obstetricians, and let's put the CPMs with the CNMs and CMs together, maybe 15,000, complete inverse. And so the difference of the pathway to education is also important. Physicians, obstetricians are trained to be surgeons. They're trained in disease management. They are trained in co-managing illnesses combined with pregnancy. Let's say multiple sclerosis or diabetes with pregnancy. Nurse midwives, which I can talk about the best, are trained in normal, healthy pregnancy. So if you or Don, if you, Don, or Nicole were pregnant, you'd come to us and say, I think I'm interested in a midwife, but I'm not sure what you do and what you offer. We're looking for assessing risk status. And depending upon the model we work in, do we work with high-risk doctors? Do we work with private family practice doctors in rural America? Our risk criteria would determine whether we could independently manage you, completely low risk, or maybe co-manage you based on what your healthcare needs were, even through the point of attend your birth, still co-managing you or not, and then postpartum care. All the time that nurse midwives and certified midwives or any kind of midwife manages a pregnancy, we focus on risk reduction, health maintenance, anticipatory education, highly, highly emphasize how the pregnant person can care for themselves and make informed decisions. They're very long visits by and large. Yeah. They are very much developing personal relationships because you have a longer amount of time, and we're afforded that time. I have many friends that are physicians who can't spend that kind of time because they're busy. So they don't know the families quite as well as the midwife does, and therefore that personal trust and relationship takes longer to establish.
For sure. I mean, I think when I started having babies, I didn't even know midwives was a thing. I mean, I thought it was old fashioned. I thought it was something that used to be kind of thing. And they were just those community midwives that when people were having their babies in rural communities, that these women would go to their homes, I think I had the typical idea of what it was. And clearly after I got into being a doula, you quickly learn that that is not true. I also think that there's a misconception of the level of education that midwives receive. So let's talk about that. What's the difference between how much time an obstetrician spends learning versus a midwife?
Well, I may get this wrong, so I hate to be exactly quoted, but my daughter-in-law is a family medicine doc with OB certification, so I can sort of go down her tree. Most med schools 4 years, then you go into a residency of 3 years in some specialty. So OBGYN residency, family medicine residency, 3 years. And in that period of time, you focus on that subspecialty. For my daughter-in-law, Allison, that was additional hours of focused care in hospital. And in general, continuity of care is what they call it, where you might be required to manage 50 people through their entire experience. OBGYNs focus highly on surgery the more advanced they progress through their residency programs. The numbers of shoulder dystocias or hemorrhages they attend may vary by the clinical setting that they're at. But if we think about concepts like breech and shoulder dystocia that are very rare, you can't like make those necessarily happen. Midwifery education, at least AMCB midwives, these are the graduate trained midwives, are looking at somewhere between 700 and 1,000 hours average of clinical experiences over 2.5 years, and they are highly integrated into that intrapartum experience as well. What we say when you come out as a graduate of these programs is there are minimum competencies that the programs are accredited that you achieve. And those minimum competencies, like navigating prolonged labor or managing a postpartum hemorrhage, right? Those things are then tested with a national board exam that verifies your safety as a beginning practitioner. It's a little bit different for midwives than physicians because OBs usually don't take their board exams till they've been out a year or so, and their numbers have to build before they go sit those exams. But what we know, Dawn, is from decades and decades and decades of evidence in the United States and globally, midwifery outcomes, based on the study you want to quote, are equal to or better than for healthy populations of pregnant people.
Right.
There is just no evidence to prove that otherwise. So the question is, why don't we have a system where healthy people know that midwives can manage you? You might even be happier and have a good outcome, and use our physician colleagues for the high risk surgical things that they could be doing.
Right. Because it's, I mean, I think that's the difference when we talk about in simple, plain English, is that obstetricians are surgeons first before they choose their primary focus. So they're trained as surgeons, where midwives, when they do their training, all they're trained in is normal physiological birth, and then that's the other difference, major difference, is physicians are typically trained in pathology, which are two very, very different things.
Yeah.
And so your obstetrician never gets that normal physiological training.
Well, there's several amazing longstanding residency programs where the midwives train the first and second year residents in normal birth because that's the exposure they get to it. So midwives are highly involved in education and training.
Well, I don't think that it's any accident that the doctors in our communities that are doing really well, in meaning like they're the people that the doulas are like, that's the doc that you want.
Go there.
Almost all of them. I mean, I can't think of a single one right now, actually, that did not train under midwives at some point.
Yeah.
It's universal across the board. These providers that behave differently, it is almost always because they trained under midwives and they got a different type of education. And I think about Stuart Fishbein talks about this a lot, actually, because he was an obstetrician and he will tell you he was incredibly arrogant. He has a podcast, Birth Instincts, which is great. But he talks about all the time that how much he didn't work with midwives until much later in his career, and how it utterly changed everything about the way he practiced.
Yeah.
And so I think that says something. And how many doulas I can say all the time, like, oh my gosh, I wish all obstetricians got to go witness home birth. I wish they got to see birth in all the different places and in all the different ways that we get to as doulas.
Yeah.
We have a very, very different perspective than anyone else in the health system when it comes to pregnant women.
Well, we had a guest on who was an obstetrician. She was wonderful, and she was very transparent in the fact that she didn't get trained or, educated in normal physiological birth. And I think there's doctors out there that know that, but there's no cross-referencing program or anything for them to even do other than to like just show up at someone's, home birth. Which is, I think also just as a point to make to our listeners too, is like, we're so ingrained as a society to ask like, oh, who's your doctor?
Mm-hmm.
Right? Like, well, what about asking, well, who's your midwife?
Right.
Or even just like, oh,
who's your provider?
Right. Yeah. Like just
I'm very good at that.
Yeah.
And I really believe in the tipping point. I don't know if your listeners are as familiar with the sociologic theory that it takes a certain percentage of the population to then identify with, oh, that's why I'm going to buy a Toyota or whatever, right? That there has to be a saturation of enough people that lean towards a concept, a product, or whatever. And in midwifery, I do believe we're getting closer to the tipping point. Right now, we're at about 12 to 13% of all vaginal births are attended by a midwife versus Mexico, Kaiser in California, Alaska, that are in the 30% and higher. They all know what midwives are there.
Mm-hmm.
Nationwide. And when we get to 18%, we're going to hit that tipping point, and our numbers have never dropped. They're continuing to rise. You add the CPMs in there with us, some say we're at 15%. So we're getting there, but not fast enough, which is why the show is so important.
What do you feel like you want pregnant folks to understand about the journey that they're on right now? And I mean, the overall, what do you feel like is the thing, most critical, important thing to know right now?
I was a childbirth educator in the late 70s. People have let go of their power. They need to take their power back. They need to learn the information, because when you don't know what you don't know, you've now given it all up. And when you're healthy, and even if you're not healthy, being able to understand everything that's important to know about trusting birth, and I don't mean that nonchalantly. To trust birth takes a body of knowledge, because it's painful and we fear it. And it's not something everybody signs up that they want to do every weekend. Then we have more control over what I would say is truly shared decision making. Because if you don't know a body of knowledge, and someone doesn't necessarily intend to scare you to do what they're telling you to do, but uses concepts like, well, everything will be better for you and the baby if we induce you at 37, 38 weeks, 39 weeks, whatever number you want to pick. Of course, you're just going to go, okay, fine, because that's what they suggested that I do. I trust the person in front of me because I don't have anything to counteract what they said.
Right. Well, and they're a medical professional, right? I mean, this doctor knows best mentality is alive and well. And I think it's so fascinating that how many people actually distrust the medical system at this point. It's talking about it all the time. Like, oh, doctors are just giving me more pills and not actually, like that exists.
Yep.
But for whatever reason in maternal health, people don't look at it the same way. And it's the same issues. It's the same systematic, financial, time constraints. All of those things exist just like it does in regular medical care.
Yeah.
But the fact that we don't understand that we are in a space that we have to advocate for ourselves is a little confusing to me.
Well, and what happened between the 70s, the 80s, where childbirth education was the thing you were supposed to do?
Right.
Right. And then all of a sudden the epidural came in and took away the pain. So now I don't need anybody or anything. To now we're going to induce you with the Arrive trial. And I even get to have an epidural and have my baby early on a day that I get to pick. It's like convenience is the answer now, instead of thinking of the consequences of these decisions. And people don't know the consequences.
Well, and no one's telling them, which is exactly why I created Birthify. I mean, Ginger, this is my biggest beef. It is the work that I have quite literally put my flag into or whatever, is that people are not being given all of the information, and they're not being told, okay, well, sure, we can do an induction, but your risk now increases for a C-section. But the Arrive trial is totally messed that whole thing up. But I've never seen anything adopted so quickly in the medical system as that 39-week induction thing. I mean, like, I'm blown away, when everything takes an average of what they say is 17 years for evidence to become practice, unless it's something that's convenient for the system.
Sure. This is what's happened in my career of 45 plus years. I used to wear the fetoscope on my head to listen to heart tones with a laboring woman, right? That was before the Doppler. I saw the Corometrics machine come down the hall for fetal monitoring. I saw the epidural come in for pain management. We saw the Arrive trial. Like about every 10 to 15 years, a new intervention comes in that magically is supposed to improve obstetrics. And what's happened? Our maternal mortality, our C-section rate is now about 37%, preliminary results for 24, and the opposite has happened. And yet the public hasn't made that connection.
They haven't. And, and obstetricians now are saying, like, I mentioned Dr. Cap a lot because he's here and we chat frequently enough. And, the thing that he's struggling with, because he's not that guy that does a bunch of inductions. He's, he believes in the normal physiological process. He was a DO first, which is very different for most obstetricians. So he was a doctor of osteopath. And then he also worked with midwives. Yeah. And so he has a very different perspective, but he's saying the thing that he's battling, people are actually leaving his practice because he's refusing to induce them.
I believe it. Dawn, if somebody tells you they're going to induce you at 39 weeks with an epidural on the day you choose, I mean, come on. We live in a very fast, responsive society. Like, if your internet's not working fast enough, don't you get a little frustrated?
Yeah, you call and you complain.
Right. So if you think you can use the system to your advantage, not knowing the consequences, what do you think they're going to do?
I was going to say, yeah, they're not sharing the risks of induction or how painful those contractions are going to be, or how powerful your body is to deliver without all of the intervention, right? They're not telling you any of that. So of course it sounds great.
Right. Well, and we're also we haven't even done enough research, by the way, because it's unethical to research on women who are in labor. But like, I have a philosophy, I guess, and that is, and it's not an unsubstantiated one, but like, what we know is when horses give birth, they have a massive rush of relaxin 3 to 4 hours before they give birth. And when you do an induction of labor, Pitocin does a great job of making your uterus contract. It does none of the other things.
That's right.
It does not cross the brain, so that the brain is not then releasing the hormones it should be releasing. I mean, we could go into like all the science of what that looks like. And then people say like, oh no, my pelvis was too small. My baby was too big. Like, give the list. When the reality is likely you didn't get all the hormones that your body would normally release in a normal physiological process. And therefore, relaxin does exactly what it sounds like it does. And it relaxes the pelvic floor and the pelvic outlet. And our babies are getting stuck. And it's not because your pelvis is too small or your baby is too big in most cases. And those are the things that make me crazy.
Sure, has changed in 40 years, maybe in 4,000 years, but in 40 years, how could the pelvic structure have changed to it? When I taught childbirth education, it was 1 in 10% cesarean. Now we're at 4. How has the pelvic anatomy really changed in 40 years? It hasn't.
It hasn't. It hasn't. But But I don't think that women are thinking about it in that large picture. And it's like, you know, most people who are pregnant right now, they haven't even thought about, or maybe trying to get pregnant, they haven't even thought about birth and pregnancy before now.
Right.
So why would they think about the evolution of it all? And the fact that the cesarean rate has increased 500% just in the last 40 years. 500%.
Yeah.
And guess what? We're not saving more babies.
No, our data continues to worsen.
Right. So I guess the thing I would love for people to understand is that the provider that you choose is critically important.
The provider and the labor setting.
Right. The location.
They're equally important.
Yes.
Equally important because the provider you choose may or may not be on call. So philosophies can vary.
That's
right. And nurses, bless them, I was a labor and delivery nurse once upon a time, have extremely high influence.
Yes.
Getting you out of bed, helping you to the bathroom, advocating for you if you don't have a doula. And once all those lines are hooked up and you're in bed, that's it. They're sitting at the desk watching the monitors.
That's right.
Because they don't need to do anything else.
Right. Well, and I think that's so surprising to a lot of people that when they go into labor, they just think there's going to be all these people in there. And then in reality, it's them and their partner, and that's it. Nobody's coming.
Point. You have everything hooked up to every body part they can possibly put in you, and it's all reading out at the nurse's desk, and they're watching probably 2 or 3 people at the same time.
Right. And they don't need to be in there unless you're ringing that bell. They're not there to help you with labor. They're not there to suggest positions. There are some amazing nurses who do it, which I love, but not everybody, certainly. Ginger, I guess when I think about like our listener right now and how somebody might be with an obstetrician currently, and maybe they're sitting here thinking, I'm not sure that this person is the right person for me. Mm-hmm. What do you think would be, I mean, I want to encourage them, right? Because it's perfectly acceptable to change providers even in the middle of labor. I've had, I know of someone who changed from an obstetrician to a home birth midwife less than 24 hours before she gave birth.
That's hard to do because trust is so important.
It sincerely is, but she went on and had this beautiful home birth. And this was somebody who was like, in the beginning of her pregnancy was like, just give me an epidural now. Yeah. Just give me an epidural now through the rest of my pregnancy. I have zero desire to give birth. I have zero, like all this stuff. And then she went on this journey, of course, of learning and seeing some red flags within her provider. And like, the more you learn, right, the more you're able to recognize like, oh, maybe this isn't the provider for me.
Well, and just before you answer, Ginger, I know with me personally, I had with my first birth, it was a practice of maybe 5 OBs. Maybe there was a midwife. I don't know at that point. I didn't see one, but came time to, deliver my baby, and the doctor on call was in the partnering practice and I never met him. So when you talk about trust, it's like, well, I had no choice, at that point. And then even with my second pregnancy, I switched providers at 30 weeks because I was not happy with who I was, going with, and switched to an OB who was amazing and had a freestanding birth center, but also had hospital rights. So I was like, this is best case scenario. And my baby was born 2 weeks after COVID lockdowns here in Jersey. So she was under quarantine because no one knew what anything was at that, in those moments. And I wound up having another midwife that worked at, out of the birth center there to deliver my baby. And she was amazing. And I think I had actually looked into her previously when I was seeking a new provider. But in those 2 instances, it was like someone I had literally never met that was there while I was in this most intimate, vulnerable state of being. which I feel like must happen be like in other places but New Jersey. Like, I don't think it's a New Jersey specific thing. It probably happens all over.
Right.
So my point is with a midwife, like, that's more independent. And I had CPMs for my last 2 births, the same CPM. She was absolutely wonderful. Like, she of course had a backup if anything did happen, but she was there. She was there through all my prenatal. She was the only one that I saw. She was there at the birth. She was there postpartum. There was no practice. There was no, she had brought her assistant for a couple visits here and there, but it was her. So, and there's revelations that I have throughout. I'm like, oh, wow. Yeah. My first 2, like, I didn't have that consistency and that trust. And, listen, I was still able to birth them, but
Well, it's getting more complicated now because we have what's called a laborist model in hospitals. And that is often an OB and a CNM team that are in the hospital 24/7, and physicians, even some midwives, care for the patient prenatally. The OB CNM laborist team deliver them, and then they go back to the ambulatory clinic, to the office for postpartum care. So we have wildly interrupted whatever continuity of care means by that kind of model. So that's what I say. Not only is the provider questions about, very open-ended. Tell me about what happens when a patient goes into labor that comes to this office, to the setting, interviewing the setting, somehow taking a tour, or finding out other people that have delivered there, or calling as a family wanting to know what happens when somebody comes to your hospital for labor, whatever route you want to use. Both of those kinds of interviews are critically important about what could happen during your experience. Mm-hmm. It is highly improbable, Nicole, that even 3% of American women have babies the way you had your last 2. That just is non-existent in our country.
Yeah.
So wild.
Yeah. Well, what the other piece of this, though, is the other part of that discussion is that Kaiser has the laborist mentality, right? That's how they practice. That's their whole entire model. And I think that we could really look at their model because they have some incredible outcomes compared to the rest of the nation or independent hospitals. And I think that it's twofold. First, they are their own insurance company. Mm-hmm. So therefore, they're motivated to keep interventions low.
Yes.
Keep inductions low, cesareans low, because they cost too much. And when that system is its own financial system, they clearly make different practice choices, and they train their providers differently. And they're looking to avoid all of these things, which I think is a glaring thing that we should be looking at. But they also have the primary care provider is midwives. Mm-hmm. But they do have, people who go in through the Kaiser system, they know from the get-go that they're not going to see the provider that they saw in the clinic.
Right.
Because it's not going to work. But they already know that.
If the philosophy matches, right? If it's all about the philosophy and the options of care. And that's what you're looking for, is when you're interviewing and asking about the processes of what are the rules? Once I step through the magic door, then you begin to understand if the philosophies match. And I'm a believer, Dawn, that it doesn't matter where you give birth. I have had a baby, 2 in a birth center, 1 at home and 1 in a hospital. And I have delivered babies in the home, in the birth center, in the hospital. It's who surrounds you. I don't care what the walls look like. It's the people that surround you and the rules that are put upon you that guide the experience that you can have.
Yes.
So those 2 things are critical, and you can't just think you're going to get a great OB provider and think magic's going to happen when you walk in that building. I don't really care what kind of building it is.
Right.
So it takes some homework and time and commitment. People spend more time thinking about buying a car than they do about their childbearing experience. Even a pediatrician or an infant care provider, there's major decisions you're making for the lifetime of this newborn from the time the birth happens. And are you going to start guiding then, or are you going to learn that information before the baby's born?
Right. I mean, I obviously I couldn't agree more. My whole premise in life is more information, because the thing over and over again in my doula practice that I heard from people who hired me for their second babies was, if I would have known this, I wouldn't have done that.
Yep.
Over and over and over again.
Told me about that. And the second edition of that book, which really does focus on the postpartum period. It's when the magic wand is waved over you and now you're home alone with this baby. Nobody told me about that. It's like 16 chapters of things people don't know because nobody focuses on the postpartum period when you're pregnant.
Right.
You're supposed to figure it out. It's the same thing prenatally, except you have these appointments where you're supposed to be able to learn things. Well, nothing is being taught during that period.
No. Nothing at all. In fact, I mean, like I mean, how many times have we had people describe how they went to their obstetrician with the list of questions and wanted to ask them while the doctor had their hand on the handle, right? Getting ready to walk out the door and not feeling like they
don't have time.
They don't.
It's like the people who are sick get more time, which doesn't make any sense at all.
Yeah.
In terms of risk reduction and prevention of possible problems.
Yeah. I mean, I hope that the thing that people get out of this episode right now is not only that midwives should be our primary care providers in maternal health, but also that it's critically important that you advocate for yourself and inform yourself. And like, if that's a formal childbirth education class, and I do mean outside of the hospital childbirth education classes are very specific. They teach you how to be a good patient. They do not teach you anything about childbirth, or very little about it. And so I always highly recommend outside of that. And then, of course, I mean, choosing something like what we're doing with Birthify, where you have a personalized coach that can literally, it's like I joke, it's childbirth education on steroids, because it really does. And there's so many options. Obviously, I'm plugging for Birthify right now, but the reality is there's so many options out there for real solid information and education, and sticking your head in the sand and just hoping for the best is 40% of the time it's not going to work out for you
or more.
Yeah.
And I also want to say, in addition to Birthify, with the Perinatal Resource Collaborative, we are starting a program to get access to those resources like this podcast, and the Amongst the Village magazine, and all of these amazing resources that we're doing within the PRC, which is filled with perinatal support professionals and all these women that we talk about and talk to every week, so that we can give women the resources. We can give them the information. We can match them with professionals in their area, and not the OBs and not the pediatricians necessarily. They're going to be the people who are giving these resources out to get them to us.
I know. Yeah, I know.
Because we know that they know where to find those people, but to give them recommendations on body workers, on, there's a question in there, not to totally, derail them from their OB, but like, are you open to alternative options? Would you like to learn more? So we can just have those conversations. And Dawn and I haven't formally talked about this, but Birthify is obviously going to be one of those resources for those moms that are not in an area where there are a ton of support professionals, because we know we have those barriers in location as well. So I think it's important, like conversations like these, to just keep happening, and like the resources getting out there. And so if you're listening to this right now, like, go share it with every mom friend that you know. Because like we said earlier in this episode, it's about changing our language. It's about normalizing, and destigmatizing almost the midwifery care, that it's not just, you know, a home birth setting where midwives can support you. And listen, I totally advocate for home birth because I had 2 amazing ones. But like you said, Ginger, it doesn't matter if it was home or in a birth center or in a hospital, it's the people surrounding you. And I was able to have an abundant amount of beautiful, supportive women surrounding me for both of those. So.
Well, I believe in this so deeply, Ginger, and everything that you're doing. Like, I actually, this last week, I was kind of doing some, you know, goal setting for me, and like even from a manifesting standpoint. And one of the things that I put on my goal was that I want to build Birthify to an extent that I will be able to eventually donate $1 million to the growth of midwifery. Because I think that's the biggest thing that we are lacking is funding. You and I both know this, that maternal health gets very little funding, although it's getting better. It's getting better, but we're always constantly struggling with the financial aspect of pushing the information out there. And so that's my goal. I like that. That's my big vision is that
is social marketing, right? We you know, call the midwife took us a little ways, but really put us over the tipping point. The American people need to understand that midwives, like I said in one of my social media posts, which I do every day, until my Lyft driver knows what a midwife is, just like what a pharmacist is, we're not going to be there. And that's only going to happen by normalizing the title, right? And that's what midwives need is marketing. More than anything else is marketing, because the myths and lack of knowledge is what keeps the patients away.
Yeah.
That it's not top tier care because they don't know.
Kristen Piscucci and I, when we were doing our work with Improving Birth, one of the things that we talked about all the time was, wouldn't it be amazing if we could have a Super Bowl ad? You know, that we got to the place that we had funding to put behind a Super Bowl ad, you know, like
Super Bowl maybe it has a midwife market the concept, right?
Yeah.
You know what we need is Taylor Swift and Travis Kelce to have and then the entire freaking world will know about midwifery care.
I want to coach her through her birth process, and then I want her to have a midwife, and like, oh yeah,
do it in Kansas City because that's where I live, and that's where she lives part of the time. So
there you go.
There we go, Taylor. If you're listening, we got you.
Right, we got you covered when you're ready to have that baby.
You know, I think what you all are doing is so important because there's a gap here that I'm identifying, right? There's the provider side, and the doulas kind of are in that now. They are looked at as a key provider, which I think is great. I did my PhD on doulas on the west side of Chicago. But they don't get to the family soon enough, right? They're already pregnant at that point, or they're 3 or 4 or 5 or 6 months pregnant. People need to be informed before they're pregnant.
Yes.
You know, and having education that sort of focuses on why. The why is it important? Begins to at least get you thinking about it. And my perfect example, and I'll keep it short, is one of my oldest son who turns 40, best friends, who I was a mother to through his diagnosis of leukemia and all the issues about future childbirth and your sperm and marriage, and couldn't get pregnant through in vitro and then spontaneously got pregnant. They had their baby maybe 2 months ago and came and spent an afternoon with my husband and I about the birth plan, you know, and this was like a month before her due date or 2 months before her due date. And what research they had found out, because they were both very highly educated finance wizards, and what they didn't know, and how to have the conversation with the provider about what they wanted and didn't want, being forced to be induced. And actually the induction was delayed until she went into spontaneous labor because of the language she used and the questions that she asked. Be left alone unless otherwise proven.
Yes.
And Went into spontaneous labor, had a short labor for a prime, and happily ever after.
Right.
I promise you, she would have been an induced C-section.
So that's so interesting because there was when I very first started doing my doula work, I started working with this one practice of obstetricians, and the one doctor was my neighbor across the street, and that's how I got connected with them. But then her partner was the one who wound up primarily referring me out to her patients. And so it was great. I mean, like, I was getting all these amazing patients and everything was great. But then suddenly I realized, like, gosh, all of the babies that she's saying are big. And we're doing all these inductions. And of course they were ending in C-sections. And I was just like, wait a minute. And I had to start paying attention to what she was doing.
Mm-hmm.
And I realized that she was consistent across the board. At 36 weeks, she would do an ultrasound.
Mm-hmm.
She would say to them, oh, this baby's getting big.
Right. Right.
We might have to do an induction at 39 weeks.
Plant that little seed.
Yeah, she would just plant the seed, and then they would call me and they'd be like, I didn't want to get inducted. Like all this stuff. And I'd have to talk them off the ledge.
Right. Yeah.
So instead, when I noticed her pattern and I realized she was doing it to everyone, I started and said before their 36-week appointment, they'd say, okay, on your 36-week appointment, this is what she's going to say.
And
and here's the information about induction for big baby. Here's the research. I would not say, don't do an induction for big baby. I would just say, here's the conversation that you should be having. And you know what happened is they would go in and she'd say, all right, so gosh, that baby's getting big. We're probably going to be doing an induction. And they'd go, well, actually, we read on ACOG that the ACOG guidelines don't support induction for big baby unless the baby is presenting over 10 and a half to 11 pounds. And are you thinking that the baby's going to be that big? And inevitably she would say, no, I don't. I'm not worried about that. I mean, it's probably like 8 or 9 pounds, maybe even 10 pounds. And they would go, okay, well, I think we're okay. I mean, babies do better when you don't induce. And guess what? She had zero argument. Zero. So then she would just go, okay, cool.
Yeah. Well,
but I just know this was the caveat. Then she would follow up and she'd say, okay, but just know I may not be there because it only if you go into labor when I'm on call.
That's right.
And then now the whole picture was being shown was that she was really trying to manage her patients so that she could be there for their delivery.
And why does she want to be there for their delivery, Dawn?
Because she's going to get paid for it. And if she's not there, she won't.
WRVUs. Most doctors are working on a salary and a compensation plan that rewards them for the work they do. So if you miss a birth, you're losing out a big chunk of change.
Follow the money.
Follow the money.
See, I wonder, but I mean, like, I'm sure that there's somebody right now going, what? Yeah. Even though your doctor has seen you in all the doctor's visits, they're not going to get paid for the delivery if they're not there.
Entire global fee because they don't mess around with the small change, which is prenatal and postpartum. The birth is the big component. And they're there, maybe an hour, if that.
Right. Yeah.
Yeah.
I wish people would just understand. I mean, that Kitty used to say all the time, Kitty Ernst, follow the money. That was her mantra. Follow the money, follow the money. And she's somebody who I love Kitty's idea of, like, the way that we grow midwives is we train nurses right away. We just start training nurses and teach them because they're already halfway there. Yeah. Through their nursing education and the information that they know, and like just educate them to be midwives. And then we have enough midwives.
You could definitely do it now that the laborist model is growing because they're not doing ambulatory clinic care. They're hospital experts, and that's what we want them to be. Just like in England.
Yeah.
So,
well, Ginger, we could talk about this forever, of course, but I hope that people got some really good stuff today and have a better understanding. And what's that book that you were just referencing? I think you said the title, but I didn't hear it.
Nobody told me about that. The second edition.
That's right.
Surviving and Thriving Through the Early Weeks Postpartum.
And that book has a whole bunch of different authors, right?
Like 16 authors.
Yeah. So like each person took a subject or
That they are really expert in. And one of the great chapters on empowerment and voice is Amber Price, who's a nurse, an executive president of Centera. I mean, she really lays it out in very clear terms how people can use their voices, and it gives examples of how you do that.
Yeah, I was trying to talk her into coming on the show, but she's very limited in what she can and cannot do from her job, from her position. So, yeah. But I mean, maybe if we just talk about that piece of it, she just doesn't want to talk about. She can't throw hospitals under the bus.
I mean, I think that would be something she would very much talk about. She's in Penny Simpkin's newest edition. As well. So focusing on those chapters, I think she probably would do it.
Yeah, I should do that. So, well, anyways, thank you so much. And so speaking of the village, Ginger, who do you think is the most important person in the woman's village besides what you do as a midwife?
I think it's reliable resources that they can learn from and begin to gain increasing awareness about choice. And I would say Childbirth Connections. There's a repository of information there from the Listening to Mothers survey about what happened in their lives, the differences between care provider types and settings, and beginning to know enough to know the questions to ask.
Yeah.
Because that is the biggest handicap, is to go in and not know what you're supposed to say.
Totally. Well, I think about when we did the beta test for Birthify, we thought that we were just going to put this resource out there and people would come to their appointments and they would have a list of questions.
Yeah.
But pretty quickly, we realized that people would show up for their calls and they would be like, I don't really have any questions this week. And I was like, oh my gosh, I have a whole list of things I want to teach you. And so we entirely switched our model. Right. And created an outline of like, these are the subject matters we're going to go over every week. We'll leave time for a little education and a little Q&A. Yeah. And that seems to have worked really well, but it was mind-boggling at realizing that like, oh, you don't even know the questions to ask.
They don't.
Yeah. And I think that's actually a problem with some of the care models that are our competitors. It's the same thing, is that the client has to have a question to ask. What's that?
They have to have baseline knowledge.
Yeah. They have to have baseline knowledge. They have to know what questions to even ask to even come and seek it. Right. And so that's, I think, that was just like a major aha moment, is people really don't know so much. They don't know.
Right.
How many OB providers ask this question on a new OB intake? Tell me the things that are important for you to learn before you go into labor and birth.
Right. Can you imagine?
Yeah. Questions to help people begin to have the permission to go on that journey of learning.
Yeah.
First, I'm the authority. This is what you're supposed to do. The implication is no questions are needed.
Yeah. Well, and I think it's ultimately one of the most important parts about a birth plan. It's like, because really, it's not really about what you walk in there with. It's the birth plan on a piece of paper. It's all of the things that you had to do to learn about those things, to make those decisions.
Right. That's right.
And people don't, as sometimes they want to just go fill it out and click it and drag it and, whatever, all these new things. But it's like, oh, that sounds good. No.
Yeah.
No, you need to read about that thing. Anyways. Well, thank you so much, Ginger. I genuinely appreciate your coming on and just being my friend, especially because we're early on in the podcast. But I know everything that you shared today is so important, and I know that people will walk away from it better.
Well, I did to share it. So let me know, Nicole, when you're ready to roll.
Yeah, for sure. And I just ordered your book, so I'm super excited to read that. Right. I'll link it in the show notes as well as all the great things that Ginger's doing. And it was so lovely to meet you. So excited we have this connection now. So yeah, thanks so much.
All right. Thanks, you guys. Hey, thanks for joining us on Speaking of the Village. If you love today's episode, make sure to hit subscribe and share it with a friend.
And remember, you're not alone. We're here, we're listening, and we're all in this together, because in our village, no mom walks alone.